Disparities. And so the task force will still have work to do probably for decades, unfortunately. So this is a good opportunity to start one that without the idea that says we end it, say, okay, but when COVID's gone, the diabetes disparities are still there, the heart disease disparities are still there, the cancer disparities are still there, the infant mortality disparities are awful and still there. And so there's all that work is still going to be there, even if the vaccine gets rid of COVID in another year or so.
But the task force might be specific to COVID. Is that so, Taylor?
I'm sorry, what'd you say?
Is it task force specific to COVID?
Is it possible? I'm sorry, I can barely hear you. I'm turning on my volume. What'd you say?
Is the task force specific to COVID?
Yes, it is.
What's the size? About how many?
We have a subcommittee and we have an executive committee. So our executive committee, it's 12 and subcommittees like 55.
Okay.
So it's almost 70 people.
Wow, that's a large group.
Yeah, it's a large group that was selected by the governor. So it's a pretty good group.
We do not have something similar in Maryland, so that's why I was interested.
Okay, good afternoon, everyone. If you guys can hear me, can you give me a big smile or a wave or something? All right, awesome. Very good. Good afternoon. We will give a couple of people, I see there are some folks in the waiting room, so we'll give them some time to get in and we'll get ready to kick off this meeting. So let's wait maybe about 2 more minutes, and then we'll go ahead and begin with our roll call.
You wanted to finish earlier?
Maybe Sunday.
Tonight, 6 p.m.
Might be walking. We'll see. Yeah. Thank you.
All right, good afternoon again, everyone. Thank you all so much for joining us today. We have some very special presentations that are scheduled during today's meeting of the executive and the subcommittee agenda of Louisiana's COVID-19 Health Equity Task Force. We just want to remind you before we move into our roll call that if you would please mute your phones until it is time for you to speak. And also, if you have any public comments, for those of you who are listening through our live YouTube stream, you may do so by sending us an email at public_comments@sus.edu, or you can give us a call at 771-4364. We have staff that's standing by to register those comments, or you, of course, can visit our website at www.sus.edu and click on the Louisiana COVID-19 Health Equity Task Force link, and you can log your comments on there. With that, we will ask Ms. Kimberly Butler, who is here with us today, to go ahead and call the roll.
Dr. Ray Belton, Kim Hunter Reed, Dr. Kim Hunter Reed, Secretary Kimberly Lewis Robinson, Dr. Katara Williams,
I'm here.
Dr. Arden Wilson, Dr. Mary Meg Brown,
Here.
Dr. Renando L. Banks, Senator Regina Ashford Barrow, Dr. Terry C. Davis, Dr. Rebecca G., Ms. Tiffany Netters, Ms. Carol Smith,
Terry Davis is here.
Dr. Davis.
Dr. Ronnie Whitfield, Dr. Gary Wiltz,
Dr. Whitfield's here, I'm sorry.
Dr. Damian Ijagiri, Dr. Eric Van Holm,
I'm here.
Dr. Deleso Alford,
Here.
Dr. Tavel Kendall,
I'm here.
Representative Dustin Miller, Ms. Alma Stewart, Mr. Christopher Tyson, Dr. Derek Riveras,
He's here.
I'm here.
Dr. Corey Hebert, Dr. Lenore Corot,
I'm here, no doctor.
Dr. Keith Ferdinand, Councilwoman Helena Marino,
Dr. Ferdinand said here, by the way.
Okay.
Councilwoman Cindy Nguyen, Ms. Janine Tate,
Present.
Dr. Alicia Bates,
Present.
Dr. Janine Thomas,
Here.
Dr. Leanne Fowler, Ms. Cindy Schneider, Ms. Kathleen Tate,
Dr. Tate is present.
Dr. Lisa Van Hoos,
I am here.
Shalina Davis,
Here.
Mr. Michael McCallahan,
3267
Dr. Connie Arnold, Dr. Faye Grimsley,
Present.
Ms. Eric Rogers, Mr. Frederick Thomas,
Present.
Dr. Demetrius Porsche, Ms. Judy Reese Morris,
I'm here.
Dr. Earl Benjamin Robinson, Dr. Peter Foss,
Here.
Dr. Kathleen Kennedy,
Here.
Dr. Robert Maupin,
I'm here.
Dr. Christy Anderson,
Here.
Dr. Takesha Davis, Dr. Amanda Dumas,
I'm here.
Dr. Amy Lesson, Dr. Ebony Price Haywood,
Here.
Dr. Margarita Echeverry, Mrs. Christian Ingle, Mrs. Tina Granger, Miss Catherine Haywood, Reverend Theron Jackson,
Here.
Miss Ruby Macklin, Mr. Ruby Macklin, I apologize. Dr. Orlando McMeans,
Present.
Miss Tiffany Netters, Dr. Rhoda Reddix,
Here.
Dr. Simone Rambati, Dr. Jacqueline Harris, Dr. Peter Kaczmarczyk,
I'm here.
Dr. Daniel Sarpong,
Present.
Dr. Sandra Brown,
Here.
and Dr. Thomas Levis.
I am here.
Thank you, Ms. Butler. Is there anyone who did not, who may have jumped on the call a little bit late and did not hear their name called?
Erica Rogers.
Got you, Ms. Rogers.
Raymond Jetson.
Okay, we got you. Okay, anyone else? All right, we'll turn it over to Dr. Brown and Dr. Levis.
Okay. Well, welcome everyone to the Louisiana COVID-19 Health Equity Task Force. And before we dive into the agenda, at this time, we would like to pause. As you are aware, our country lost a civil rights giant last week. And on behalf of the task force, we would like to pay tribute to the late Congressman John Lewis, whose legacy of activism transformed American democracy. So let us take a brief moment of silence in his remembrance. Thank you. At this time, I would like to refer to Dr. Levis, my co-chair, who's going to introduce our two guest speakers of today. We are excited that they have taken the time out of their busy schedules to meet with us and present the wonderful work that they are doing. Dr. Levis.
Sure, thank you. Thank you. And let me first say we thank you all again on this task force for your diligent work in putting together the initial set of reports that we've sent off to the governor. We don't have any updates on it just yet because we're still awaiting the governor's response, and we'll be discussing more of that later. But again, thank you for the dedication to the important work of this task force. It clearly comes through in the work that you've submitted. It's my pleasure to introduce to you two friends and colleagues from the state of Maryland, who are all of our colleagues, as they are also long in the fight to address health equity in this country. As you know, that we've been reaching out to other states and bringing people from around the country to talk to this group about what's happening in other states so that we can learn from their experiences. Likewise, we have been presenting in other states as well, the work that we're doing. Today we have Dr. Noel Brathwaite, who is Director of the Office of Minority Health and Health Disparities for the Maryland Department of Health. He's an international public health expert who gained experiences working with health issues in the United States, the Caribbean, and parts of West and East Africa. And prior to joining the Maryland Department of Health, he organized the Greater Los Angeles Health Network to collaboratively tackle urban and suburban issues of health that continue to disproportionately impact people of African descent. We also have Dr. David Mann. David is epidemiologist at the Office of Minority Health and Health Disparities for the state of Maryland's Maryland Department of Health. David has been in this role for, I don't know, it feels like forever, David, well, we've known each other and been doing this work. In addition to working for the Department of Health, David is also an instructor in the Department of Epidemiology and Public Health at the University of Maryland School of Medicine. Welcome, both of you virtually to Louisiana, and we look forward to hearing your presentation on the work that's being done in Maryland.
Thank you. I have the great honor to once again collaborate with Dr. Levis as we did previously, and I want to thank you for inviting us. We are going to divide ourselves into two parts. Dr. Mann would be the first one to present. He would deal with the data, and then I would come and talk about the response from the Office of Minority Health. So are you ready, David?
Yes, let me bring the slides up here and get the screen sharing going. So hopefully everybody's got a nice big screen slide view there. Somebody will let me know if that's not the case, and I'll start moving forward. So I'm very pleased to receive the invitation from Dr. Levis, who was one of the many formative people in my understanding of health disparities and health equity starting in 2004 when I first came to the Maryland Department of Health in the role of the epidemiologist in the Office of Minority Health and Health Disparities. And so definitely, he may not have realized it since I wasn't one of his official students, but definitely had a lot of influence in my thinking. And I want to thank Dr. Levis for that. As we go to talking about how Maryland's been handling data, my guess is that you're probably a little more interested in how we do the data than exactly what the Maryland data are. So I'll try to make sure I talk about how we do things as well as what the findings have been as we move through. So the presentation is going to cover four main areas: some health disparity basics, some ways that we in our office think about health disparities, and particularly talking about the role of social determinants. We'll look at some of the Maryland COVID-19 data by race, ethnicity. Then we'll talk about how there are the disparities in social determinants and how they kind of drive these disparities through the comorbidities. So I'm going to start with this diagram that that I like to use because it helps me think about how health disparities that we measure in data emanate from the causal factors, and the root causes are the social determinants of health. And I'm going to, for this presentation's purpose, assume you guys have heard about those. So rather than belaboring that, they're all on the list in the column on the left. But from a data perspective, they all move forward to influence four kinds of metrics that I try to track. One is the prevalence of the causes of disease. How frequently do people have these risk factors, high blood pressure, obesity, things of that sort? And then also tracking how well are people able to get access to prevention services and what's the quality of the services they can get. And then further down, there's also a severity level of the risk factor. So one group might have more high blood pressure than each person with high blood pressure might have a higher blood pressure than the other people in another group that have high blood pressure. So severity as well as the frequency. And then what's the access to and quality of treatment services? And we look at those measures, and then they bring us forward to two other metrics that are really important. How frequent are these ultimate diseases that we're worried about, and how severe are they? And then that moves forward to the ultimate outcomes. We look at death rates, hospitalization rates, things of that sort. So in the context of COVID, if you've got a group that's got twice as much disease, you're twice as likely to be infected. And then if once you're infected, you're twice as likely to die. That group's going to have a 4 times higher mortality rate per number in the population. And so these disparities, as they track through these boxes, very rapidly start to multiply together to give you a multiplicative kind of synergistic increase when you get to these final outcomes of death and disability and hospital utilization and things of that sort. So I find this to be a useful conceptual model for thinking about data. The other thing I think about with data is that we need data to do three things in health equity. We need to do a needs assessment step, and that's basically asking who's got the problem, where is it, and how big or bad is it. And that's usually done by the public health system using surveillance data. That's kind of the stuff I do. And then we have intervention planning. So why are these disparities there? What's causing these problems? And how do we fix it? What are the evidence-based interventions? And that's where getting the answer on what to do is really developed by our academic partners using the research data that they develop. And they provide that evidence base for us. And then figuring out where to do it is us going back to the public health surveillance data and figuring out what are the hotspots to target. Then last step is evaluation. Are we making progress? Is what we're doing working? And that's basically doing that needs assessment step repeatedly over time to see if we're making any difference. So then everybody in health equity is always looking for disaggregated data, and COVID, lots of people were requesting everything in every which way. Everybody wanted to know racial ethnic data by zip codes and things of that sort. So it made me think about the challenge of doing that. And the problem is there's just tons of it. So if you take COVID data, you can think of analyzing 8 different kinds of outcomes in 7 different ways of organizing population groups in 5 different levels of geography using 3 different kinds of metrics. Is it a raw count? Is it a population rate? Or is it an age-adjusted rate? And then you can create a time option where you're getting a one-day snapshot, a cumulative look, or a daily trend line. If you multiply that together, that's 2,500 different ways to look at data. And if you have a question you want an answer to, it turns out that only one of those 2,500 ways of analyzing it is the right answer to your question. So it gets really important to understand all these different ways of doing data and making sure you match up the question you have to the kind of analysis you're trying to get. Otherwise, it's easy to get misled by data. So this is always something to keep in mind. Then we're going to be looking in a minute at how we've had excess rates for our minority population in Maryland for a lot of COVID-19 outcomes. And so I thought I'd start by talking about what are some of the reasons why that's happening. And so one of them is that there's a likely higher minority frequency and incidence of cases. So minority populations are more likely to become infected. Why is that? They're likely to be more frequently employed in the essential occupations that have to keep going to work and keep getting exposed to the virus. They're less able to telework. And so those two things mean there's a lot more spread from household to household in minority communities because they're picking it up from work, they're picking it up from places outside the home. And then minority populations are more likely to be living in larger families that are in smaller houses. So they're high density, often very multi-generational. And so it's much harder to isolate a sick person in a household like that. And so there's going to be much more spread within the household. And so if you're twice as likely to have your household get it and you're twice as likely to spread it in your household, you can easily get to being 4 times bigger on the incidence rate for the disease. And then why would the severity be worse once you're infected? Why would death rates and hospitalization rates be worse for minority populations on a per case basis? And that comes from things like higher general stress due to community violence, poverty, and racism, less access to resources, which poverty and racism play a big role in as well, and also the higher prevalence and severity of all the comorbid conditions that seem to be driving the bad COVID outcomes, hypertension, diabetes, asthma, things of that sort. So a lot of things are kind of stacked up against minority communities in trying to handle the COVID virus. So looking at Maryland, one of the things we often think about is where do things distribute by place? This map's probably a couple of weeks old. I didn't quite have time to get it all updated to the latest thing for this, for the postponed presentation. But you can see that, and hopefully my cursor shows up as a pointer here, kind of down the middle here. This is the little keyhole of Washington, D.C. Baltimore is up in here. And the I-95 corridor, of course, is our big population density strip. Our 5 big jurisdictions here, Prince George's, Montgomery, Anne Arundel, Baltimore City, and Baltimore County. They have 4 million of our 6 million population, so they've got 2/3 of the group, and so they've got the vast chunk of the cases, as you can see. And this is looking at a map just of the counts. Where are the counts the highest? Well, it tends to be where the people are the most populated, and there it is. So counts tend to show you the burden. If I want to know where I need more ventilators, I look at a map of counts. But on the next slide, this is now the rate per 1,000 people in the population. This was actually a chart that the Baltimore Sun put up. And suddenly you see that some big dark things showing up on the Eastern Shore where they're not highly populated, but the density of cases per population is getting almost as high as some of these central areas. And what's being shown in the slide that maps out the population rates is actually giving you a measure of the risk and where the risk maps across the state. So if you wanted to know what's the chance that the next person I bump into is more or less likely to have COVID-19, this is the map that tells you that. The previous map would tell you how many ventilators do I need to ship to which county in a certain sense. So each kind of data tells you a little bit of a different answer, and it's all designed to answer different questions. So this is the analysis of just the distribution of some of our outcomes compared to the population distribution. So in the yellow bars, we've got the percent of cases by Black, Asian, white, Hispanic, and then other people who specify other race. Our American Indian population is only about 1% of the population, and trying to get meaningful data there has been challenging for us, so we don't have that here right now. So you can see the cases, and then in orange, we've got the hospitalization share, then we've got the mortality or death share, and then we've got the share in the population. So for the Black population, their cases, admissions, and deaths are higher than their 30% share of our population. For Asians, those things are all a little bit lower than their share of our population. For whites, it's all lower than their share of the population, which is 51%, and Maryland will probably be a majority minority state by the time we get the 2020 census numbers in. And but you can see that for whites, the deaths are a much higher share than their share of the cases and the admissions. And part of that's because the cases are much more shifted into the older population in the white population of Maryland. So that does give them a higher death share compared to their share of the cases and admissions. And for our Hispanic population, it's kind of flipped the other way. They're much higher in the cases and the admissions, but lower in the share of deaths, and their death share is almost level with their share of the population. And that's because the Hispanic population is much younger in terms of who's getting the disease. And so while we see it a lot in the hospitalizations and the admissions, it's not showing up as much in the deaths. And then the other population is not too far off, but a little higher again in cases and admissions than their population share. So now we get to a couple charts going to look like this, and this for an epidemic where you're really interested in how this is progressing over time are the really important kind of curves to look at. And they're a little bit complicated, so we'll take a second to kind of walk through this. The black line up here, and this is the case count, the raw count here. This black line is cases per day for the Black population. This is a 7-day average, because otherwise it looks like an earthquake chart. The Hispanic population is here in the blue. The white population is here in the red line with the open white circles. And what you'll see is that clearly the Black population has everywhere been higher than the white population at every point. So clearly a higher count of cases. Then if we turn that into a rate per 100,000 population, you can see the Black line is here and the white line's down here. So again, at every point, the Black rate is higher than the white rate. The Hispanic rate has been shockingly and surprisingly high, and it came up in terms of the raw counts with a much higher raw count, a much later peak. The other two groups peaked about here, but all groups did eventually finally start to come down, and the case counts actually got pretty close together out here around the beginning of July. And then we've had an increase, particularly for our Black and white population, not quite so much for Hispanics, but I wonder if that might be the 4th of July party weekend that got us into trouble here maybe, but no way to know that for sure. Again, looking over here at the case rates, which kind of changes the scale on everything, dramatically higher case rates for the Hispanic population, finally starting to get into the ballpark with at least the rates in the Black population, since it did finally come down. And we do see, again, this late rise of both the white case rate and the Black case rate since the beginning of July. So I think we may be in the middle of getting to our next ascending section. A lot of this is fueled by people in younger age groups than we saw previously, so it hasn't hit our death rates so much just yet. But this kind of analysis does allow you to answer several questions. Are the groups significantly different from each other is one question, but the other question is the trajectory different between the groups? Because the absolute worst case scenario would be to put an intervention in place and have the white rate go down and the Black rate keep going up. So I think we at least were able to get somewhat parallel curve bending, if you want to call it that, for at least our Black and white populations. And our Hispanic population, we did kind of get the curve to bend down, but it did come a little bit later after a higher peak. And this is just a lot of discussion about what that is that we've already talked about, so I'm going to skip through that. Then if we look through what happens when we look at death rates and death counts, here's the counts of deaths, and they're pretty much the same in terms of count for the Black and white population. Then you have to figure that our Black population is 30% and our white population is 50%. So when we convert it to rates, again, it's a big rate disparity for the Black population compared to the white population. And it does finally start to converge together as we get into the end of June. The Hispanic counts have been relatively low because most of the cases have been in young folks. And those rates, though, did end up starting out approximately where the white population was, eventually came to be about where the Black population was. And because the Black population dropped faster at that time than the Hispanic population in terms of deaths, there was a time when the Hispanic rate was the highest for the daily rate. And now they've all converged to be kind of similar in terms of death rates. And then one last point, sometimes you hear people say, oh, COVID is just flu. Well, we clearly have seen disparities in death rates with COVID-19. And this is our chart of what flu and influenza looks like in Maryland. And we generally do not have minority disparities in flu and pneumonia mortality rates. So the fact that one produces a disparity and one doesn't tells me they're not the same thing by any stretch of the imagination. So why is it that minority populations are doing so poorly with COVID? So minorities have a higher disease prevalence for several comorbidities. So here we see with diabetes prevalence, the white prevalence rate here, and all the minorities are higher than that. And the Black-white ratio, for example, is 1.66. Then if we look at things like ED visits, diabetes ED visits, 3 times higher for Blacks compared to whites, asthma, 3.5 times higher, high blood pressure, again, 3.25 times higher. And this reflects the increased severity of the disease as well as the increased frequency of the disease. So really large disparities in how sick people are with the disease. So clearly more of the comorbidities, more severity in the comorbidities, that's going to be a bad omen for COVID outcomes. And so where do these disease disparities come from? So looking at our data for prevalence of diabetes, looking in Black versus white in these two lines, now across an income range. So this is incomes ranging from less than $15,000 a year to higher than $75,000 a year. You can see that generally as income starts to go up, the prevalence of diabetes starts to go down, and that's true of each group. You also see that despite similar income levels, there's a gap between Blacks and whites, so it isn't all an income factor. And it's also interesting to see that the affluent, the higher affluent Black rate is actually a little bit better than the poor white rate. So some of these problems we talk about, they're not just exclusive to minority communities. If we put the same kind of adverse social determinants of health into a white population, they'll have some of the same kinds of health problems as well. So, but what's really interesting on this chart to me is that these curves actually diverge a bit. So if we think of income as a protective factor, it looks like the protective effect of income on whites is a little bit stronger than the protective effect of income on Blacks. So we have to think, why is that? Why would something that's supposed to be good for you be more good for you if you're white and less good for you if you're Black? And I think all the things that relate to racism and constant the issues that we see there, the kind of stresses that produces are probably a large factor in why that's different. So, and then the other thing to notice, and this is, I think, our final slide, is that the distributions of income aren't equal, and also distributions of education aren't equal. So here, if we get to the lower income end, the percentage of the population that's low income is higher for Blacks than for whites. They kind of meet at the 50 to 75, and then at the greater than 75, there's a big gap between what percent of the population, whites versus Blacks, is at that most affluent income level. And so not only is income is going to be helpful, there's more disparity at every income level, and you're more likely to be at the lower income levels that do worse if you're Black compared to white. So a lot of factors and social determinants that are really the root causes driving all of this, and that start at the left side of that chart we talked about toward the beginning and move their way across to the right to get to those ultimate outcomes of deaths and hospitalizations and things of that sort. And that's the end of the data presentation. I'm assuming we're taking questions after Dr. Brathwaite's presentation.
Yes.
And I will unshare.
Okay. Thank you, Dr. Mann. You know, there's a mantra that says, follow the data. So that's what I'm going to be doing, to follow the data to determine what extent can interventions assist in better coping with some of the disparities and inequalities. We started with the Eastern Shore because of an outbreak in the rural community, especially among poultry workers. And what we sensed was, based on the assessment, that there were a lot of social needs of those who were impacted by the coronavirus on the Eastern Shore or rural communities. So our partners from MOTA, we fund community-based organizations and faith-based organizations. And in a package, we call them MOTA, Minority Outreach and Technical Assistance. And so we were able to mobilize them and provide those who were going to be tested, farm workers and poultry workers from Mexico and Haiti. A number of them were undocumented, but they were nevertheless working in the poultry industry, a very critical industry in Maryland. And so they came down with a number of cases of COVID. And what we did was to call on our partners in the MOTA and also the churches, as well as community-based organizations, to assist those who are affected by the coronavirus and their families with care packages. That model of collaboration and also mobilization was used later in the course of the virus. So that phase one is what we consider to be establishing some kind of model that, if called on later in the disease process and later in the overall process, that we could use to successfully intervene. Our Eastern Shore model was a success in that close to 10,000 packages were distributed on that part of Maryland. As we followed the data, we recognized that other larger jurisdictions were also greater impacted over time. That brought us to what we consider to be the big five counties in Maryland, as Dr. Levis would remember. Prince George's County, Montgomery County, also Baltimore City, Baltimore County, and Anne Arundel. Those were the big five in that they have the largest count and the largest number of cases of COVID-19. And so we felt that we had a responsibility to do something about the marginalized and vulnerable populations who were unfortunately impacted by the corona. And so based on the needs assessment that were conducted by those county health officers, we appealed to the CARES Spending Committee, because the CARES Act provided funding for interventions. So those 5 counties were targeted, and the CARES Act ends in December. We started in June to mobilize resources for those 5 counties. And so as of today, we have allocated about $1 million to assist those 5 counties in many of the socio-economic impact of the coronavirus. And we hope that by the end of December, with the end of the CARES Act, that we would have assisted a significant amount of individuals with some of their rent, some of utility, some of them by getting insurance coverage, food, and other amenities that would help them cope with the COVID. We also went to another level in our response to the disease. We wanted to know more about some of the factors that were contributing to the disease, and that brought us into touch with the HBCUs. So we again appealed to the administration to fund the 4 HBCUs in Maryland: Coppin State, Morgan State, and the University of Maryland Eastern Shore, as well as Bowie. Bowie, as you know, Louise is in Prince George's County, and Morgan is within the Baltimore City, Baltimore County area. Whereas on the Eastern Shore, you have all the upper, lower, middle Eastern Shore counties serviced by University of Maryland Eastern Shore. And we also have those two in Baltimore area, Coppin and Morgan. So we felt that it was important for these HBCUs to become involved in studying factors that were contributing not only to the disease, but also the attitude of the recipients of social services to these services, and also the attitude to communication and messaging, as well as one interesting study would look at telehealth. To what extent can telehealth help patients in the rural community nursing homes cope with the disease? Because we know that about more than 60% of all deaths from coronavirus occur in the nursing home residents. So the University of Maryland Eastern Shore wants to do something to telehealth to the extent that they are able to do some better coping mechanisms of those who are in the nursing homes. Another interesting study is going to be done by Bowie. They wanted to know what was the impact of blood transfusion on those individuals who received it, and if they were able to relay some gains from that blood transfusion. Another study looked at the health belief model and to what extent the health belief model is able to predict health-seeking behavior. We felt that it was important for the HBCUs to be involved in these studies so that we can get a better grasp of what was taking place in the lives of our minority communities. The other intervention that we use is what we consider to be statewide intervention. The big five, those were targeted to those counties. The Eastern Shore was targeted to the counties on the Eastern Shore within certain areas. And then we had the HBCU concentrated close by. But the one that was a statewide intervention is what we call the messaging and communication intervention. There were some misconceptions about the disease that we felt it was important for us to message, not just in terms of a global message in Maryland, but a message that was specific to minorities in both English and Spanish. And so one of the things that we did was to provide funding through the CARES Act to about 3 or 4 minority focused media outlets, both on the TV with PSAs and the radio. And one of the innovative things was that the NAACP, they got a flatbed truck, and they moved into some of the key communities, the key zip codes, with messages that we felt should be duplicated across the state. They started in Baltimore City with the flatbed truck. And so we felt that this was a good idea to fund them to go to some of the key zip codes in the big 5 communities to let them hear from the local influencers, those who can influence the messaging and communication about masks, about contact tracing, and also the importance of social distancing and getting tested. Those 4 levels of intervention, we believe, would demonstrate not only that we care about our communities, but they will give us a better understanding of what happens to those who are provided with care and those who might be neglected relative to an understanding of some of the drivers of these conditions. In Maryland, we believe that the Office of Minority Health has a great role to play in eliminating disparities and also achieving equity. And so we follow the data wherever we can, whenever we can, and to the extent that we can bring resources to those areas that are pointed out by the data. And we believe that this strategy of following the data, as you do in Louisiana and as most public health professionals do, would give us not only the opportunity to serve the minorities in the areas that are hardest hit, but will provide us some guidance that we can provide reports to the legislature and also to the funding sources that we can make a difference, not only in terms of the disaggregation of the data, but in supporting the social and economic needs of those who are negatively impacted by the disease. It was a pleasure to bring you this report of what is taking place in Maryland, both from the data perspective, and to get the data was a struggle, I should say, because prior to intervention, the data was not disaggregated by race and ethnicity. So we had a great struggle to get that done, and we were supported by, it took some legislative rate, I would say, some legislative rate to eventually have the data displayed by race and ethnicity. And I think a number of politicians were behind this, and they supported the efforts of the office to get that data done. I would hand it back over now to Dr. Levis, and we are open to looking at some of the questions that you may have to address to both on the data side, as well as meeting the social needs of those who are negatively impacted by the coronavirus. Thank you.
Thank you. Thank you for that presentation, and we'll open it up for questions from any of the taskers. And I'd like to start with a question for you, Noel. Wondering, issue of trust. The communities that we're all working with are communities that have justifiable distrust of government and other institutions. That distrust having resulted as a consequence of many years of untrustworthy behavior, to be perfectly candid. Talk to us about how that issue, how you've addressed that issue in Maryland, gaining the trust of communities and to get them to participate in the interventions you've been developing.
Yeah. It has, well, we know the history of distrust within not only Maryland, but across the US. And what we did was to acknowledge the distrust, to get the government to recognize that there was distrust and that the communication cannot be a global communication, but the communication should be targeted, and the use of community influencers, individuals who looked like community members, individuals who came from the community, individuals who targeted the community, and organizations like the NAACP, WMAR Radio, that has a large Black following. And so by getting the kind of input from the local health officers, and also putting out the message that we care about what is taking place in the community. Not only are we giving you the data, it's one thing to highlight the data, but the second way that we wanted to bring a level of trust in government through our office was to demonstrate, and we fought hard to get resources to the community. If the people see that we care and that we can respond to their need for food, their need for rental assistance, their need for utility assistance, I think that would break down the distrust that they have in government, because when people are feeling pain and suffering, and if you just provide them with data, there's a disconnection, but by helping to relieve pain and suffering and let them see that we care and that the local actors, those who are with them in their communities, and can point to the fact that, yes, this organization that is representing the government, we have their backs and we know that they care about us. You can trust them. So I think that combination of listening to the community and responding to the plea of the politicians for data by race, ethnicity, and responding to the local needs for assistance in their daily living, those created elements of trust. The other thing is that is for contact tracing. The benefit of that trust is that not only the testing, but also the contact tracing, because if you don't trust the system, you're not going to provide the system with the kind of information for your contact tracers to use to get better handle of the transmission. So I think that we not only responded to the needs for data disaggregation, but also to the needs of the suffering and the pain that they were experiencing. And those helped to build trust for the office.
Okay, thank you for that.
If I could add a quick comment on the trust question. I think community health workers are one of the kind of policy initiatives that can be used to really try to deal with the trust issue, because you're taking people who are trained up from the community, who should hopefully be trusted community members, to do a lot of the work in the community. And in Maryland, we focused on that a lot with the Health Enterprise Zone project that I think Dr. Leviste will remember. And also, we currently in Maryland have a community health worker certification program. We're certifying training programs that meet minimum requirements, and we're certifying folks who've received and passed those training programs to kind of help create a workforce of community health workers that I think can help us surmount the trust barrier. So from a what's a policy proposal perspective, I think a community health worker focus is very useful.
Okay. Any other questions? Well, Dr. Brathwaite, your counterpart is Dr. Earl Benjamin Robinson is on the call. I hate to put you on the spot, but I'm going to do it. Put you on the spot and ask if you had any questions or comments or reactions to any of what you're seeing there in Maryland.
Is the question to Robinson?
It's to me?
Goes to Earl.
Okay.
As the counterpart to Dr. Brathwaite, or Noah Brathwaite. I don't know if you've met, but you.
We haven't met.
Yeah, I think
did you virtually?
Helpful if you two.
Yeah.
So yeah, we need to exchange information. I do like what you stated previously, because we are having issues we believe that have to do with trust as it relates to contact tracing. And so we're in the process of, sorry about that. We're in the process of doing focus groups inside of the state to see how we can better execute contact tracing. I had the privilege of a few weeks back of just reviewing some of the materials, and we will start reviewing those materials that they use to train contact tracers in the States. But I had the opportunity to review it a few weeks back, and I provided some feedback. And so we are putting in measures to just monitor the situation better, make certain that we are properly training individuals, because I think that's probably one of the biggest things is making certain that there are people, we are choosing the right people, and we are helping people to understand the importance of finding commonality with the people that they are contact tracing. That was some feedback that I got from one of our contact tracers probably a while back, and she shared that, we have to share a lot of information with them, and it's quite overwhelming to a lot of people. But this contract tracer told me that when she was able to let them know, I have individuals in my family who have experienced this, and we're going to get through this. She found that when people saw that commonality and that helped to advance the trust there, and she was able to get more information. So I do believe that trust is going to be something that is really needed to get the data, to get people to share information as it relates to what's going on with them with COVID-19 and where they've been and who they possibly have come in contact with, because it continues to be a problem. And so we just want to work to do it better. But I will get your contact information. I will be in contact with you.
Okay, I appreciate that, and I look forward to collaborating with you. And the lessons that you learn in your contact tracing, because we have just we have just put together what they consider to be a contact tracing unit. And they will be asking us to identify a health educator to go into the community to help with training and so on. But I think the secret of contact tracing is not necessarily at the information level. I think you hit something, is more at the experience level than the information. If you can share your experience, and very often, you know that a number of, in Maryland, we have a large Hispanic community, possibly you might have in Louisiana. And the secret of getting through the Hispanic community is not by more information, but the understanding of the culture and the understanding of how they lived experiences. And that's why they said, if you can give us someone who looks like us, and the whole system of provider relationship, Black males would rather go to a Black doctor. And so I would suspect that if you use that model, that Hispanics would rather, in confidence, provide information about their contacts to Hispanics who look like them, who understand their culture, who might understand the whole notion of agents of the government asking questions, and we don't want to out our friends by giving them the correct address and giving them the correct information. So when you call, don't answer the phone. You know, so I think it's a matter of living the experience that will make a difference in contact tracing. Information is good, but those live experience, and if you could get contact tracers who have lived the experience, who look like them, you have a better outcome than just sharing information.
Okay, thank you. We're running a little late, and so we're going to have to cut off the questions here. I'll be happy to connect the two of you via email, so you all can communicate later going forward. Okay, so I'm going to turn it back over to my co-chair, Dr. Brown.
Thank you, Dr. Braithwaite and Dr. Mann, and thank you, Dr. Levice, for arranging these two guest speakers to present today. And if anyone needs their contact information, I know our communication and messaging committee would probably love for you to network with you on best practices of what you all did when you went out into the communities to deliver those culturally relevant messages. So, you know, we would love to collaborate with you further, but thank you again. Are there any public comments? No public comments. Okay, the next thing on the agenda we'd like to share with you is our Facebook page. And I don't know if Korth can show it up, but the Communications and Messaging Committee, and with the assistance of Janine Tate, has launched our Facebook page. And Tracy, right before the meeting, sent it to you all. And so we want you to like it, share it, endorse it, get the message out. We'll be using this Facebook page as one of our platforms for posting, you know, videos and messaging, utilizing this platform among others. Dr. Rivera, so you were on the call. Is there any updates you'd like to give us about any messaging or communications outreach initiatives since we last spoke?
Yeah, we have been working as a subcommittee to try and increase the number of messages and the content. Right now, we've got several in production, including a messaging on the safe way to wear masks, the appropriate way to wear masks, the safe way to distance, the appropriate way to distance. We're also beginning conversations about end of life messages. We know that in a lot of these communities, conversations have not begun about how we are to respond to questions about terminal care. And so we're going to begin a message campaign on that. As well, we're looking at ways in which we can inform our community, much like the presentation that just completed, inform our special communities, our unique communities about the importance of vaccination. We know we're working on that down the road. This is time, though, for us to start figuring out ways that we can get messaging in so that we can get past the distrust that was mentioned, so that we can get not only past the distrust, but also make sure that our people are able to get immunizations. If there are a limited number of vaccines, how do we make sure that we're participating in that part of the healing process? So got a lot of work going on, messages going up. Janine has been very good about helping us to get that out, and stay tuned, you'll hear more.
Thank you. Thank you so much. We have been in contact with our donors. They have been receiving our reports and they have read the reports and they are very impressed with the work that the task force is doing. And so we have been keeping them abreast. Just want to share with you the COVID-19 Ochsner prevalence study is still underway. They're trying to finish up. I think they were trying to recruit 1,000 participants. But if you could spread the word about the prevalence study, that's happening here in Baton Rouge. It's a sister study to the one that was done in New Orleans. And so the next thing on our agenda has to do with next steps. And so Dr. Levice and I have received the next steps from recommendations from each subcommittee. We will be compiling them, taking a deeper dive into what would be the next steps as you all generated from your subcommittees, from the work that you have done. And so we will be putting that together and disseminating that out once we've received it and flushed through it. The Health Equity Task Force will meet again August 14th. And at that time is when we will have a representative from the governor's office, either Secretary Kimberly Robinson or the governor himself will, perhaps his schedule will allow him to meet with the task force. And so they are in the process of reviewing all of the recommendations and the reports that have been submitted to them. We've been in conversations with Secretary Robinson, and they will be presenting to us on that date feedback from our recommendations. So the task force, want to allow them the time to really do that and provide that to us. So we will not be meeting on August the 7th. Our next meeting will be August the 14th. And on the agenda, we'll have feedback from the governor's office. At this time, we'll entertain any questions that the committee may have. No? Dr. Levice, you have any questions or?
Nothing from me. You've covered everything we've discussed.
Okay. All right. Well, again, we thank you. We thank you for the meaningful work that you have done. The reports are being read. We are getting feedback, and we'll get a more formalized feedback on our recommendations on August 14th. In the meantime, stay safe, mask up, and enjoy the rest of this time that you have as we move forward with our agenda.
Great.
so much. And thank you to our guest speakers. We appreciate your presence today.
Great. Thank you all.
Thank you.
Thank you.